All right, everybody. Hey, this is Steve Sir Heinrich. Thanks a lot for joining. We're ready to get started with the second edition of Curvo Quick 30. Appreciate everyone who's dialed in and got onto the Zoom webinar. I am actually sitting here with Dr. Anshuman Singh. We met Dr. Singh about 4 years ago. I was flying back from AAOS and met him on a Southwest flight back to San Diego, and so we've been friends since. And so we're honored to have him join us. He's a top orthopedic surgeon in San Diego, and we also have Andy Perry, who is from Curvo, and will be leading the sourcing piece of the conversation. And Dr. Singh will cover the physician perspective. So Andy, I'll turn it over to you to take it from here.
Yep. Thanks, Steve. And thanks so much, Dr. Singh. And I will say one of the folks in that picture is a lot better looking than the other. And I don't want to necessarily hurt Anshu's feelings by saying which one, but
it's all CGI, Andy. It's all CGI.
Well, as Steve mentioned, we're really honored to have Dr. Singh joining us today. Just a quick recap for those of you. This is a new series, the second in our Quick 30 series that we're doing here at Curvo to really paint the picture at the category level from a sourcing perspective, a clinical or physician perspective, and really try to help the supply chain subject matter experts in this category be the partner to the clinical organization that you can be, and that we all want to be, really, to help move the needle on cost and quality. So, Steve, thanks for the introductions. That's a little bit about the Quick 30 in general. You'll see us continue to do these kind of category by category. We may spend a couple of sessions on a few different aspects or elements of a particular service line or product category. Today, it's sports medicine. We are, again, really, really thankful to have a guy. It's basically the Michael Jordan of shoulder surgery in San Diego with us, Dr. Singh, one of the highest volume shoulder surgeons in that area, assistant professor at UC San Diego, Berkeley undergrad, UCSF Medical School, Harvard Fellowship trained, just an outstanding guy, doing really awesome work there in San Diego. So, Anshu, thank you again for your time. We'll spend a little bit of this first part of the discussion today just getting your perspective about how you learn about devices in the marketplace, how you learn about device costs, your research interests, all that good stuff. We've got a lot of words up here on the screen for those of you in the audience. We'll stay somewhat tethered to this, but not completely, and then we'll dive into some market data on Curvo for a little bit of strategic direction. These questions are pretty basic. If it's something that you want to use to survey or panel your medical staff, please feel free. It can be very effective for learning about how your medical staff team members are getting information about costs and about devices. So if it's all right with you, Anshu, let's go ahead and get going. Does that sound good?
Yeah, great.
Perfect. All right. So I know that you're, extremely busy and productive surgeon focused on patients, lots of clinic time, lots of case time. How often are you looking at new products in general?
Yeah. So I would say that, it's interesting for me personally, because I have an interest in product development and things like that. I do from time to time look and survey and see what's out there via the internet usually. But I would say that the standard probably answer for this is it's really led mostly by the companies, right? Because oftentimes I'll be approached by local reps and salespeople, and they'll sort of show me what's new and shiny. And also, it's driven a lot at meetings. So most surgeons will go to 1 or 2 meetings a year, and they'll sort of go walk by the booth and sort of see what's new. And of course, advertising. I do read a couple of journals every month, and so I would say journals, meetings, and kind of what the sales reps bring to us are the 3 probably most common ways that surgeons hear of new products.
Mm-hmm. And so, and forgive my ignorance here, but AAOS, is that generally the most common professional association for sports medicine?
Well, for sports, there's also subspecialty meetings. I go to the shoulder society meetings. There's also arthroscopy society. So there are other subspecialty meetings, but of course, the AOS is the largest orthopedic meeting in the world, I think. So, so you probably have the most number of surgeons there, generally speaking. But there are other, like 2 or 3 other fairly large meetings in the United States, at least.
Yeah, gotcha. And then as you're hearing about these new products, and as you said, it's primarily led by industry or by device companies. What criteria is kind of guiding you as you decide what's going to pique your interest or be worth a look?
Yeah, it's interesting. I would say the first thing is especially in sports medicine, there are a lot of products that are brought to market that don't stay on the market for a long time. So I think especially the longer you go in your career, you sort of have seen those cycles. So most of us will first look at it and say, gosh, is this something that I think works for the patient and will improve outcome? I think that's always the first question I think surgeons ask themselves.
Mm-hmm.
Then the second thing is, can I use this given my skill set? There are new things, new procedures that, oftentimes you didn't train to do them formally in your residency and fellowship program. So there's a comfort level with that. And then the third thing is maybe cost and sort of workflow. I would kind of bundle that with workflow. Cost is usually not, I think, the first 2 or 3 things most surgeons think of. Well, I can give you like an example. Like the clavicle is an area that I'm very interested in. And there are a lot of designs out there for clavicle nails. And even though biomechanically it's a better construct, most surgeons didn't train to put them in. And the way you put them in is really counterintuitive. So even though it does make sense a lot of times from a biomechanical standpoint and maybe from an outcome standpoint, because people are comfortable with the technique, those haven't taken off in the last few years. So that's just like an example of maybe something that makes sense clinically, but because of skills, because you kind of said, oh, skill set, huh? But because of training reasons, it's difficult for people to implement.
Yeah, no, it's fascinating. So if you think about kind of the noise and the friction point, you use the word kind of the shiniest device or the shiniest widget, and there's a lot of noise around the meetings or attention from companies being paid to that. But your filters are looking for quality outcome for the patient and maybe what fits my training, really is what might. So we hit the quality outcome improvement for the patient. It fits from a technical perspective, your approach, your training, your normal way of doing the case, and then maybe we're thinking about, okay, what's the cost issue?
Correct.
Right. Okay, and so that's kind of the sequence.
About a really novel new product, right? They are sort of, I don't want to call them Me Too products, but they are sort of iterations of products that are out there. For example, in sports, a medial row rotator cuff anchor. Sometimes the company will say, hey, we put vents on this anchor. And you put it in the same way. You know what I mean? It's really for the same application. So you're like, yeah, if it's on the shelf and it does cost about the same, I'll use it,
Right.
So that I wouldn't consider that necessarily a new product. The company may try to sort of sell it to the payer as a new product, but from a surgeon standpoint, if it's very familiar and it fits the same need and it costs around the same, I don't really, that for me it doesn't strike me as new, versus a new shoulder replacement or whatever.
Definitely. So just an incremental improvement for sure.
Correct.
Right? On something that you're already doing that kind of fits you in stride. Definitely looked at differently than a new technique or a new procedure.
And I'll tell you that is, we're off the record a little bit here, but that is always a very tough. It's not always so simple as, hey, this is a new reverse shoulder versus an anatomic shoulder, which we can all say, passes the eyeball test as a really new implant and a new technique versus an anchor that now has a little hole drilled into it to vent, whatever fluid away or into the space that you desire it to be. There's sometimes it's a little bit less clear, and a company will bring an institution a product, say it's totally new, and want to charge twice as much for it, but then it's not really that new. So this is really a wedge point, and it's not always so clear.
Yep. Well, I think it'd be really insightful for our audience because this is the struggle that folks in the supply chain are dealing with on a very consistent basis, and just to be able to sit in your shoes for a moment and understand how are you personally parsing those decisions. First of all, even to find out what the cost difference is in is in the devices. How are you learning that information? And then as you're really pairing up, is this incremental? Is there value here? What are you doing personally to kind of come to those conclusions?
Yeah, well, the first thing is, as a surgeon, you have to learn what the cost is. And it's perhaps not surprising to the people on this call that surgeons generally don't know how much things cost. There have been several studies. One of my friends at Duke, he's the chief of shoulder there, he did a survey study where they surveyed a bunch of doctors and said, hey, how much do you think this anchor cost, this nail cost? And if they got within 25% of the cost, they consider that a good yes answer. And the vast majority of surgeons could not get within 25% of the cost.
Right.
So it's perhaps unsurprising that we are very ignorant of that data. So first of all, you have to, as a surgeon, you have to get that data. And as you said, a lot of times that's not on our radar. So as a sourcing person, I think, we can talk about this later, but one of the key principles, I think, to being efficient in your line is to be transparent, and that includes internally within your organization. You have to be transparent, especially with the end user, the surgeon. So at Kaiser, one of the things I really pushed for was to allow the surgeons inside our Epic system to check the prices. So at the end of the case, all the implants that were scanned in, we could now go and look at the cost of them. So I think it's difficult to control something that you're ignorant of, right? So you really need that data. The end user really does need that data. So now it's easy for me to check the prices the last few years, but I do encourage everyone in this area that that needs to be very evident to the end user. And it's really almost not fair to expect them to care about price if they don't know it.
Yeah, no, exactly. Or as we've done some of these, and I think you may have listened to the GI one that we did most recently. Physicians are often finding out device costs from the reps themselves. And
Correct.
Whether that's a consistent or reliable or always accurate source, it's probably debatable, but it also is showing the void that supply chain needs to be filling as the partner in providing data and educating our medical staff members on what things cost. So
correct. I mean, it's a little bit of the fox guarding the hen house, right? In that situation. So I would actually, this is one of the beauties of your platform is that with Curvo, you guys have that really neat heat map view where, I mean, that sort of simplifies it. But I think, if there were in an email form every month or quarter to every surgeon on your network and say, these are the top 20 implants you use and this is how much they cost. I mean, I think that something like that would be very digestible that, we could look at on our cell phones or whatever. But I think that closing the loop on cost is really important. And surprisingly, again, not in the surgery center environment, it tends to happen more because surgeons' interests are more aligned, in the financial aspect of it. But in the hospital environment, I can tell you it's not very transparent for us.
Yeah, gotcha. Okay, well that's good to know. And I guess for our audience, if you're listening, Dr. Singh is just kind of saying to keep your medical staff in stride, something they can look at on their phone and a quick snapshot out over email, letting them know what their devices are costing, not foisting any behavior or practice pattern difference. It's just providing data, showing that comparative. Am I hearing that right, Anshu?
Absolutely. And surgeons, we at least like to put ourselves out there as being data driven. And if, I think it's important to provide it to us.
Yeah, perfect. Well, before we leave this series of questions, you mentioned that you got maybe a subset of products that you would call Me Too, where the technology is not substantially differentiated. And then maybe you've got another stratosphere where there is some differentiation and there is some clinical consequence. Could you maybe parse that out for us? Let us know what products are kind of Me Too for as we get a little deeper into the category and maybe how it might lead into a sourcing strategy. What are some things that really are a price play versus other things that have a clinical consequence?
In particular, in sports medicine, for example, I would say like a medial row anchor is kind of a commodity product now. I don't think that there have been any studies showing a differential outcome based on the anchors. And implementing them technically is almost always the same. So I would say that it's a commodity product. And just you move over a couple of centimeters in a lateral row anchor, for example, while I think the outcomes are very similar. Their implementation of whether you use a Smith & Nephew, Arthrex, or MyTech product, it's technically, they can be very different to put in. And there's quite a bit of like surgeon comfort level with that, Labral anchors, I think, are essentially commodity products. But then you go to, very new procedures, cutting edge stuff like the superior capsular reconstruction. Some people may be familiar with that, where, there's a new dermal graft, to use all these anchors and things like that. That's like a very new product that really, one company, Arthrex in particular, has provided the implants for that. So that's something that really no one else at this point, I think, has a very competitive product for. So that's something that's really, new. I mean, there, of course, there's probably hundreds of products we can put into these categories vaguely, and some in the middle. But, I think, for example, shoulder replacements are very different still, especially the reverse shoulder between companies.
Sure.
Are very different in terms of the number of screws, the offset options, the augmentation options. But if you look at, for example, a total hip, now the total hips are really converging, and they're pretty similar across companies, So even, in arthroplasty, for example, there's some that are like hip and knee that are essentially pretty commoditized between the big 5-6 players.
Sure.
Versus shoulder, which is, if you look at a DePuy shoulder, it's very different than if you look at an Arthrex shoulder, or you look at a Right Medical shoulder. They're very, very different.
Yeah, no, definitely. And you might want to be cautioned there. If you keep demonstrating more expertise, we're going to invite you back for the shoulder arthroplasty webinar too. So.
Oh, probably more in my wheelhouse, but yeah. Okay.
And then just really quickly before we leave this page, if you don't mind, elaborate on any sourcing committee or value analysis committee work that you're doing, and the extent to which you're involved, if at all, there.
Yeah, and in years past, I'm actually in my organization at Kaiser, I was one of if not the highest utilizer of total shoulder, actually. So I sat on the committee. At Kaiser, we break it down by sort of implant. There's a hip and knee, there's a shoulder arthroplasty, there's a sports, there's a video. So it's because it's such a large organization, there's little committees on all those areas. So I sat on the total shoulder committee for a few years. Now that I do a fair amount of research at UCSD, and I have a closer sort of relationship with some companies that way, I've stepped away from it for a few years because I don't want to have a research relationship and then also be on the steering committee for implants. So I was in, and the way it's set up here, I can't go into, I guess, 100% detail, but essentially you have 3 or 4 clinicians per committee. You have, folks with MBAs that also that look at that side of things, and then you have supply chain people, and so we all sort of work together, and we have a couple of meetings a year, and the surgeons sort of will opine on some of the things you're asking me about. Is this an equivalent product? Is it fair to ask the same for this and this? And then the other folks will go in and negotiate with the companies more directly. So
sure.
Yeah, so I sat on that for a few years.
Gotcha. So do you find that most of your discussions with your peers were kind of confined around products, were confined to that committee work, or is it much more organic and happens kind of in
a little bit of both? I do when I was doing on that committee, I had a formal capacity to sort of solicit feedback from my work group. So certainly I would go and ask local surgeons, hey, what do you think of the Right Medical total shoulder? What do you think of this? What could you, do you think, because we want all the surgeons to feel like they have buy-in in the process. So for example, if I were setting up something similar at an outside institution, I would, go to the 2 or 3 biggest practices that your hospital services, and I would ask for maybe a surgeon from each of those groups to represent them. And that way, if you switched anchors from company A to company B, all those guys could say, hey, this is okay with us because we're, getting better service or better price or not. And at least they will feel like they're a part of the process. And now you put it on that surgeon to communicate with his or her group, and be a rep. So to that aspect, I did have, I guess, non-organic, email solicitation of people's opinions, but I also, as sort of, a person who does a lot of these procedures, just in the back hallway, doctors will ask, "Hey, what are you using now for your totals? What, what do you think of the new glenoid on something?" So there are those organic conversations that will continue. But I think I think it's both.
Yeah.
There's some organic.
Okay. All right. Well, wonderful. Yeah, I'm very curious here in these last 10 minutes or so to get your take on some of the market data that's coming out of Curvo. So this is our look at the market as a whole for sports med implants and disposables. In Curvo, we try to do a few things to leach out any statistical relationships between market share and price performance and volume and price performance. You can see that there's just a little bit of upward price pressure, pretty modest, going on in the market right now. It's actually a slightly inverse, albeit weak, relationship between price performance and market share, a weak direct relationship between volume and market share, and then about 67% on average for the top incumbent. If we look over to the right, and then probably no surprises here, all those green dots are Arthrex, is really having by far the largest amount of the market share. If we kind of go into individuals a little bit, this is where I think we can start to shape maybe some action items for our audience around sourcing strategy. So we're isolating down now just to Arthrex, and you can see, and Anshu, I'm curious to see what you think about this. You can see where we've got a lot of density in price around the median performance there. Not really a ton of variation up or down in Arthrex. And what that's really suggesting is that across a lot of different market share, across a lot of different volume, those would be the bubble sizes, you're still seeing a lot of concentration around the median. So not a ton of variability in Arthrex pricing, regardless of where your market share moves or even regardless of volume in some cases. So is that pretty consistent with what you would think, Anshu, or what you might hear in the market or in your work?
Yeah, I think so. I think Arthrex is the dominant player, in this space, and they probably, I think it's safe to say that they have probably the most forward-leaning, innovative products, generally speaking. So I think, it's not surprising that they're very consistent with their pricing, and because from what I can tell, a lot of their pricing, is done by a smaller group of people. They probably try to hold a consistent, point for that.
Yeah. No, I'd say that's distributors. That's proven out there, and from a sourcing perspective, unless you're a couple of these hospitals doing appreciably below the median, you got some opportunity to catch up. But if you're at the median, there's not really a whole lot of chance for you to move. Now, where I would see opportunity from a sourcing perspective is I would look at this data and say, if I were to peel off some of the business, you look at what Anshu has said, where medial row or labral anchors are basically commoditized. If you want to put that business out for a more competitive bid and peel some of that away, you're probably not going to see a major price consequence, or at least you'll have a pretty strong leg to stand on for why there shouldn't be a price consequence on the existing book of business that you leave there. So that's the way I would look at it from a sourcing perspective, is let's take the book of business and let's find the elements of that business that are more commoditized. Let's see if we can't do better on that subset. And we should not, statistically, from a market perspective, have a major price consequence for peeling some of that away. So, not an attorney.
That's a good read of the data. I really think that you're right.
Yep. And I'll make whatever supply chain disclaimers apply, like attorneys and accountants do. Don't rely on me for et cetera, et cetera. Let's move on now. Let's see if we go to our next one. If we look at Smith and Nephew, now here we've got a little different shape, and I picked a few different ones of these just to give us some good stuff to talk about here. But if I look at the Smith and Nephew data, definitely. And I'm going to change my color of my pen here. Definitely directionally, visually, we're seeing much more correlation there between a better price performance, more market share, and to some extent a little greater volume, bigger bubbles. If we go back and look at the whole market, not many other competitors to Arthrex besides Smith & Nephew had as much market share in other accounts. And that was kind of interesting to me. Now, I would look at that and think that suggests that Smith & Nephew can cover Arthrex better. Anshu, what are your thoughts on that? Is that off?
Cover that, you mean they have analogous products?
Little greater maybe than some other players, a little broader product.
I mean, a lot of companies are trying to compete in this space. You know, ConMed, Smith & Nephew, Mitek still makes some decent products, you know. I mean, so yeah, I think so. I think that's true. Yeah, so Smith & Nephew is a competitive company for sure. You know, there's no doubt. Yeah.
Yeah, I mean, I would look at this and pretty much say, if you're going to expect to improve upon your Smith & Nephew pricing, it's going to be pretty quo. You know, you're going to have to be able to move some business or increase some volume in order to do that. The data would suggest. You know, we got a few little extraneous bubbles here that I wouldn't necessarily try to draw too much from. But for the most part, directionally, if you're going to improve on your Smith & Nephew pricing, you're probably going to have to get some market share volume in return. Any other thoughts there, Anshu?
No, I think that's pretty accurate.
Okay.
Yeah.
And then the last one you mentioned, DePuy Mitek, I pulled them out as well. So J&J, large company, of course. What's standing out to me about this data is, first of all, we've got such a narrow band of market share, so really not able to cover in many cases much more than a quarter or so of the market share, not garnering as much, but pricing really all over the place. Kind of fascinating. Bit of a concentration down here below the median, but wide variation in the spray, no real correlation. Anything to read into this, Anshu, from a product perspective?
Yeah, it's really interesting. You know, again, I should probably do all the legal disclaimers and whatnot, but it would seem in the last couple of years that J&J seems like they're concentrating more on their sort of core trauma and hip and knee business.
Mm-hmm.
And they're seeing, certainly in shoulder arthroplasty and in sports, their pace of innovation it doesn't seem like it is what it has been in the past.
Gotcha.
So it's possible that that they're ceding some of this to those other companies. The products that they have are pretty good. They have very good biomaterials, and their commoditized products are actually, I think, very competitive. But I would say that the pace of innovation on those new, the buttons, the sort of biologics, and some of those kind of new areas that the other companies are pushing into, it seems like it's slowing down. So,
okay.
So that shrinking market share probably fits with that.
Okay, no, that's a very helpful take on some of what might be behind this data. So small market shares, possibly due to a lack of innovation that's maybe hampering some of the breadth of products to compete with the larger players in the space. I'm very interested in the wide price spray, really up and down this price performance continuum. So, very interesting. And you're saying that their products stand up very well on the materials, on the more commoditized or less differentiated products. So, if you're a sourcing professional, could be that Mitek would be a worthwhile look because there is good pricing out there, but it does seem pretty hit or miss. If you're not performing well on your Mitek pricing, there doesn't seem to be an intelligibly strong rhyme or reason for why that might be. So I don't know.
The other potential issue is that J&J is such a large company and they provide such a breadth of services outside of sports that oftentimes they may bundle it with their other business. For example, your hip and knee business is probably, fivefold as much as your sports. So it is possible that in some of these places they've given them a steep discount because, they've signed over their hip and knee business to them or their trauma line, or maybe if you only have a sports relationship with J&J, you won't get as good a price. So some of this is probably not just their volume in sports. It probably represents their volume across lines, the pricing, I would guess.
Yeah.
Because they're such a broad company, you know.
Yeah. Yeah, it could be that it might be part of a multi-line pricing strategy. Yeah, definitely.
Right.
Well, you know, I
whereas
think
Arthrex, not as much, you know.
yeah, right. No, definitely a pure play there. Much more so. Good call. So, Steve, I'm going to turn back over to you to open up for Q&A. Just want to thank Anshu again, but I know we've got questions from our audience and folks that probably have a couple of questions for him. We want to be respectful of everyone's time, but also, take that opportunity to open questions up.
Yeah, absolutely. Thanks, Andy and Anshu. That was a great conversation, and we do have some good questions that have come in, and I want to get to those. So first off, one for Anshu, Dr. Singh. The question is, from a surgeon perspective, how can supply chain personnel best leverage negotiations with vendors for sports medicine products when market share, surgeon preference, and rep relationships are so widespread?
Yeah, it's an awesome question. I would say that, I'd maybe take a step back and say, you know, if you're coming up with a strategy in general to engage your surgeons in the process, first of all, it's important that surgeons are engaged in the process. Obviously, more so in some areas, for example, if products are clinically equivalent or not, or, you know, technically easy to put in, but surgeons need to be engaged in the process, and they should sit on the committee as well. And they should be privy to the data. So I think, number one, must involve the end user in the process. So involve surgeons early and more often in areas where they're useful. Number two is being transparent and sharing price data, service data. Hey, this rep is really available for us. These guys are great about delivering things on time. These guys aren't. I think that's also very, very critical. So being transparent with your data. And I think, what else was in the question here? Yeah, and I think number three is to align your interest with the surgeon. I will tell you that the same, I mean, I've been doing this long enough and have enough friends around that I can take one of my friends who owns a share in a surgery center and will only use 2 anchors and sort of the minimum amount that is clinically necessary in that environment, and then they'll go to the hospital across the street and be completely insensitive to that aspect. So you want to align your interests with those people as well. So, you know, there are a lot of strategies on how to do that, but basically, that's another very, very, very big part of it. And, you know, again, when they're on the committee, you can ask them, gosh, you know, what do you guys use in the surgery center? You know, oh, you use Arthrex there. Why? And we use my tech here. Why do you, you know, then you can ask the why questions, you know, and I think those are basically, I guess, the issues. But you're right, you know, obviously some of those relationships the companies establish purposefully because they're sticky relationships, and, you know, surgeons will move with reps sometimes, you know. So, but you want to keep the focus on the institution. So yeah, like one of the things I was suggesting is to engage, especially if you have a big group of 20 orthopedic surgeons, have them assign a person, you know, on the sourcing committee, or, you know, one for multiple sourcing committees. And I think and that they can take it back, because, you know, we meet with our groups once a month, once every other month, and they can say, hey guys, the hospital wants to look at our spine contract. What does the spine guys think? You know, can you use, you know, J&J versus Medtronic, and what do you guys think? So I think, you know, to share that aspect with them, I think is important.
Yeah. Well, you know, you bring up a good point too, and I've always thought, when you have practitioners that are deciding, do I bring a case to my own ASC, or do I take it to the hospital? You know, a lot of times, frankly, those decisions come down to the profitability of the payer or that particular patient. And it seems like, from a supply chain perspective, it's a pretty good opportunity for give and take. That, you know, okay, well, it's part of our mission. We will gladly, accept this, public payer patient, et cetera, but we need you to work with us on the cost of the devices that you're using. Is that a reasonable approach to conversation in the situation that you're talking about, a surgeon that's got his or her own ASC, and then they're also doing cases at the hospital, or are the decisions behind it different, where I'm thinking about it wrong?
Well, I think it depends on a couple of things. One is sort of what alternatives you present them, as long as that they're quality products,
Sure.
and you're not, I think it's a little more palatable, and probably also what the surgeon's alternatives are. If there's, a competitive hospital a mile away that will say, just we'll do anything and we don't care, right? You're sometimes only as faithful as your options sometimes, So I think, in general, though, I think that's fair, that that at the very least you can have that conversation,
Yeah.
Yeah.
Okay. And Steve, any other questions we've got from the audience?
Yeah, we do. One that I think is really interesting is kind of around the trends of surgeon buy-in. That if you look back in the 80s, I mean, there was no relationship between surgeons and the hospitals, and things have changed quite a bit. And so the question is, when you're at AAOS or other conferences on SHU, and you're hanging out with your friends who are other surgeons, other places in the country, you're obviously talking about clinical practice ideas, but have you noticed, or do you see it now, are people talking about, when they're having beers and hanging out, does cost come up and supply chain come up at all? Have you seen any trends in that?
Does cost and supply chain come up? I guess it does sometimes, it really actually, I'm trying to think back now. That's a good question, but I don't think it comes up as often as you would think. It is certainly clear that the trend of the surgeon administrator is a much more common scenario now too. Before it was sort of like a handshake relationship, and we were not very involved, whether it's supply side, whether it's making protocols for outpatient surgery, or having an orthopedic floor that you're the co-director of. That kind of stuff is much more common. So I think we do talk about surgeons in sort of assuming a more administrative role, like I sit on the whether it's the pricing committee or the negotiate with the the payers, our rates and stuff. So I do think that surgeons are more involved in negotiations and in more sort of administrative practices that we weren't in before. I don't know that cost comes up like much more often, in that sometimes, hey, I can't use this company stuff because it's too expensive. That happens from time to time. People sometimes
like they'll say,
yeah,
I can't use it anymore because
yes,
they won't come down. And
the
hospital won't let me.
Correct.
But
correct.
Is that a supportive type of, and I'm willing to do that sort of thing, or is that I'm not happy about that?
I'm not. Usually, I'm not happy about that. Of course, usually over beers with friends, talk about things that you're frustrated about. So oftentimes it'll come up like, hey, I can't use this spine implant because it's too expensive, in my system. So I do think that that certainly happens, and I think surgeons are becoming more comfortable with assuming a larger administrative role, whether it's in the supply chain capacity or another, more managerial capacity. I think it's more familiar to us now.
And another question is kind of off of that. Anecdotally, have you seen seen any surgeons leave an organization due to pricing disagreements?
It's really rare. I have seen it. I could probably count on one hand, and it's usually a surgeon who's either a design surgeon or who's a very high level, has a high level of involvement with an organization. And then if there's some kind of major dispute, that they'll leave. But I can think of 2 times where someone has changed surgery centers or a hospital in one case I can think of, but because they designed a certain implant and it was like it was pretty imperative that they continue to use it so they can speak about, their own creations with authority, So I think it's really, really rare. So to your point, I think that that it's a sort of frustration, but I don't know if it's like a deal breaker, if it was like untenable for the hospital. I mean, I think ultimately we want our hospitals and our organizations to succeed, and if something costs twice as much or whatever, I think we understand that in general.
Yeah, that makes sense. All right, we got one more question, and then this one is actually more, I think, for the audience. So I'll throw it out there to Andy and Anshu if there's any questions, but it comes from Mark, and I'm sure Mark would appreciate feedback from the audience too around this, because it's something he's wrestling with. And I think it's great to for these opportunities to get input from your peers too. So the question is, and it kind of ties into trauma too. In the sports medicine / trauma area, we are at risk for increase on our trauma spend because the podiatrists in our area do not want to use Synthi plates and screws in voluntary procedures. However, most items cross into the Synthes trauma contract, and we are required to have 80% Synthes spend in that space. We're hovering at 79%. The impact of dropping a tier is almost $250,000. And then the question is anyone else wrestling with this bear? So Andy or Anshu, I don't know if you got any perspective on that, but certainly the people in the audience may have some, and you can feel free to email me and I'll connect you with Mark to share some ideas.
Yep. My question would be, is the sports lumped in with the trauma? Is that, and we are seeing an absolutely from another audience member. This is not you,
awesome.
Mark. Yeah, just so you know, but that would be my first question. It is lumped in. Okay. So, all right. So let's just try to tie this up in a neat little bow. You've got this multi-line issue or this multi-line contract, and sports and trauma are lumped in together. I'm hearing from Anshu that J&J's got decent price or decent products that we can see in our data. You can get a competitive price on in the Me Too stuff. So, if you got 1%, I would look into that sports spend and see if there isn't something we could pull away to get that 1% of the market share teetered back over to J&J. Now that this is a shot in the dark, but if they're lumped in together, we're hearing directly on this call today from a surgeon saying if we're looking at medial row, labral row anchors, not a whole lot of differentiation. Is there a little balance of business that you can throw to tip the scale back that way? That's the way I'd look at it. I don't know how insightful that is for you, Mark, but that's my initial reaction in reading that. Anshu, anything differently you'd say?
No, I mean, that's really interesting. You may want to go to the podiatrist and say, hey, guys, look, we're 1%. Oh, is it 1%? They need to go 80%. Yeah, we're 1% away. Like, are you guys okay with using this for ankle fractures or whatever, some other things that they can move over? And then on the next contract, why don't you guys sit in on the contracts or we'll open it up to other companies that may give us a better, Right Medical or whoever makes good foot stuffed Arthrex that they want to use. So, this could be one of those things that you just go to the guys and say, hey, look, this is $250,000. This is a big deal to us. And can you guys just tip the scale a little bit? And then on the next round, we would like you to sit at the table and look at the whole thing with us,
Yeah.
It may be that they're just like, oh no, product X is just so much better, but it's hard to imagine that they couldn't push it a couple of percent on, because there are enough equivalent products really in the foot that they should be able to do that.
Mm-hmm. Yep. So Mark, has the impact of that drop been shared directly with the podiatrist so that they know what kind of dollars we're talking about? I don't know if it's possible to reply in the chat, but another audience participant, Leslie's suggesting that if you can leverage a little bit of opportunity on the sports side, it might make J&J back off. And it sounds like the dollars have not been shared with the podiatrist. So I think Anshu's got a great point. These ladies or gentlemen find out that you're talking about $250,000, they may very well find a little balance of that business to keep with Synthes or to move over to Synthes in order to keep the piece there. So I think those are all great suggestions. This would be a great opportunity if we've got more thoughts around this from our audience or Steve or Anshu, anything that comes up after this, to give our folks a chance to stay connected and answer some of these questions and help one another. But really appreciate that question from the audience. Pretty good one to get group feedback on.
Yeah, that's great. I love seeing the different people on the chat responding there. Thanks, Mark and Leslie, for filling in there too. So we're coming up at the end here. Want to be respectful of everybody's time. If you go to the next slide, Andy, we have future quick 30s coming up. In 2 weeks, we'll be looking at recon total joints, and then we'll be scheduling these others. We also have last week's available on the website to review, and we'll continue to post these afterwards. And then the next slide has contact information. If you have any additional questions or just want to reach out, don't hesitate to reach out to Andy or Anshu. They're both available. Andy, if you'd hit that next slide too.
Oh.
And then I want to remind everyone with these other webinars that we're doing, these webcasts, we're looking for more sourcing perspective on there. So if you have been working on any of these categories and have something you could share and be on the webcast, we'd love to have you join us in this conversation. It's really simple, just talking about some of the things you've done, sharing suggestions. It would be great to have you on, so please reach out and let me know. I'm at steve@curvolabs.com. Of course, you can reach Andy at curvolabs, and Anshu, his email address is there as well. Well, thank you, everyone, and thank you, Anshu. Thank you, Andy.
My pleasure. Nice conversation.
Yeah. Thanks so much, Anshu.
Have a great day, everybody.